Times have changed, bringing with it numerous changes in almost every aspect of life. Lifestyle has changed. Due to advanced information technology, communications, digitalization, today time is critical for virtually everything. Time is the essence. Today, fast world has also created various unwanted conditions like stress, work issues, anxiety, giving couples very little time for themselves. The result: increasing cases of erectile dysfunction. The result: less time for building relationships. The result: unhappiness. Zydus Forteza, a division of Zydus Healthcare Limited, launching for the first time in India the fastest acting phosphodiesterase type 5 inhibitor. Presenting avanext, Evanafil 100 mg and Evanafil 200 mg. Happiness is mutual. Why wait? It's fast. Onset of action in just 15 minutes. Best among all available PDE5 inhibitor. It's effective. Improvement in SEP2, SEP3 and IIEF scores. It's safe. High tolerability and safety profile for diabetes or cardiovascular patients. It has no intake restrictions. Eat and drink what you like. Can be taken anytime. It has least adverse effect. Less incidences of headache, blurred vision and nausea. Let them experience happiness that is mutual. Let's make every patient of ED happy. For the first time in India, presenting the fastest acting PDE5 inhibitor, avanext, Evanafil 100 mg, Evanafil 200 mg. Happiness is mutual. Why wait?
So very good evening to the respected faculty and our viewers. Myself, Dr. Sachin Chaudhary from Medical Affairs Team Zydus would like to welcome you all for today's event on a knife on the reproductive organ can cure its dysfunction. Now, sexual health has an integral part of men's well-being, but it has always been less discussed or ignored due to variety of reasons. Now, at Zydus, we put a constant effort to improve the male sexual health. So to continue our efforts, today we bring to you a masterclass series where the experts in the field going to be discuss on few of the commonest issues faced by the men's. So without wasting much of your time, let's welcome the moderator for today's session. For the same, we have with us a Professor Dr. Deepak Jumani sir. He is a senior sexual health physician and counselor, a diplomat American board certified clinical sexologist, an ASECT certified sex therapist. He's been attached to Sir JJ Group of Hospitals and Grand Government Medical College, Mumbai. He's been the editor of International Journal of Psychology and Counseling. He's also been the course director and mentor of Fellowships in Clinical Sexology, a program run by MUHS. He's been the co-chairman in IMS Initiative for Sexual Health, and he also received an Dronacharya Award for his excellent work in the field of CME in the year 2019. And also he is an author of one of the largest seller book, that is A Sex Has No Expiry Date. So thank you so much, Deepak sir, for accepting the invitation. With that, now I request to take the things ahead. Over to you, sir.
Thank you very much, Dr. Sachin, for that warm introduction. Um, Welcome, a very, very warm welcome to all my respected teachers, guiding guides, friends, colleagues, ladies and gentlemen. Today we are going to witness a feast of knowledge. We have been treating male sexual dysfunctions with pharmacotherapy, but at times pharmacotherapy doesn't help. So we need to do something to give them a good quality of life and have satisfying sex. Well, the second and the third line of treatment, which is there for many patients who have sexual dysfunctions, is surgical treatment. But yes, it needs to be done with caution. It needs finesse. It needs precision. And to tell us all about how a knife can cure the sexual dysfunctions in males, we have with us a fantastic panel of experts. Dr. Rupin Shah, who needs actually no introduction. To introduce Rupin is just like showing a lamp to a rising sun. He's one of the best teachers in andrology, especially with sexual dysfunctions, treatments of infertility. He is the teacher of teachers, a master teacher. He must have taught at least more than 1 lakh urologists across the globe as to how the surgeries are to be done, and all the science and wisdom of the practical surgical treatment for various dysfunctions which are there. He is also a Dr. B.C. Roy awardee. He has written several papers, and he's been one of the best speakers of every conference on urology or sexology which we have. One thing about him is I have seen him operating. The finesse which he has, the caution which he takes is the result of what patients benefit. He also has pioneered of implant by himself, which nobody in India has ever done it. And one more feather in his cap is that he's done the maximum implant surgery across the globe combined, whatever whichever country you take it. He is the number one surgeon in a microsurgeon in the field of urology treating sexual dysfunctions. We have another eminent faculty, Dr. Rajeev Suth. He is a dean of RML Medical College in Delhi. He is another master surgeon, a very good dynamic leader, a statesman, a fantastic surgeon. We also have Rajiv Kumar from AIMS. He's also a very good microsurgeon and has got a lot of finesse and precision in his surgery. A lot of accolades to his credit too. To I also welcome my mentor, my teacher, Dr. Jayalal, who is the president of IMA headquarters as the national president. One thing about Jayalal is he's the professor of surgery at the Trinavala Medical College in South India. I read his biodata, which is about 40 to 50 pages. I don't want to go through all that. But what I was impressed is he wrote in the end that what I am today is the gift of God, and what I become tomorrow is my gift to God. What a fantastic way to live his life and give a meaning to his life. He's got several awards. He's a crusader for helping every IMAite who could do something better, and he has improved the conditions of IMA at Delhi and all other things. He is proactive in many things, especially in the education front. He has fought for all the medical fraternity for their rights, and I also welcome Dr. Jayalal. We also have Dr. Dilip Maheshkar, who's the Director of Medical Services, Government of Maharashtra. He'll be joining us soon. He is a pulmonologist, a fantastic human being, very humble, down to earth, practical, and has always one thought that he would like to help every doctor, every medico who seeks his help and wants to improve the conditions in the municipal and government hospital across Maharashtra. With these short introductions, may I now invite Dr. Jayalal, my friend, my teacher, my mentor, who's also the national president of Indian Medical Association India. And I would like him to please inaugurate the webinar and also give us some pearls of wisdom. And I want him to please explain to us that why still sex is still a taboo. Why not IMA is taking up certain steps to bring DNB in sexual medicine and MD in sexual medicines. We do have fellowship courses, that's okay, but we need something more to, because this is a branch which needs really push from leaders like Dr. Jayalal. I welcome Dr. Jayalal. Please let us inaugurate the webinar and also give us your pearls of wisdom. Over to you, sir.
Thank you very much, beloved leader Dr. Deepak Jamani. Distinguished members of this esteemed branch of medicine, the sexual medicine, much sought after, much important innovative field. Distinguished speakers and the very renowned surgeon who is doing a yeoman job in the sexual medicine, Dr. Rupin Shah, Dr. Rajiv Sooth, Dr. Sachin, Dr. Aravind, and all my distinguished members of this panelists and also the people who are doing this. Indeed, it is my great privilege as a national president of IMA to officially inaugurate this program on the sexual medicine. It is quite a different program, and as usual, whenever Dr. Jumani is organizing any program, he always gives not only the content, the attractive name or the title which he gives will always have a lot of importance and meaning on that. And he has put a very important type, a knife to cure for the sexual medicine and a relief for the sexual medicine in a very any appropriate sense he has put it. Of late now, people are now a lot of understanding the importance of the sexual medicine and the avenues and treatment available. Unfortunately, if in India, the most of the quackery and most of the unscientific medical treatments, if it is offered, it is on the field of either the sexual medicine or the mental health. But today, with the committed leaders like Dr. Tibak, Jumani, and other people, now more and more people are now open to discuss about the sexual issues and coming forward to get the updated and the advanced medicines and the treatment modalities they are available. The era of the pharmaceutical management is there on one end, but it couldn't give the optimum result to many of the people to various reasons. But I'm sure the like any other surgical condition, and now surgical implantation or the penile implants are providing a very great relief with an affordable and accessible way, and people are able to experience their positive health. We know we are really in the era where there is a geriatric or the age of the people living is becoming increasing. So once upon a time, age 50, 60 is considered as a old age. Now it has been the prime youth of the people at like what we see Dr. Rajiv Sooth and at the age of he will not reveal his age, but they all looks youth. That is the time that we youth. So this is the time where we need this treatment modalities available. Definitely, today's webinar, which is going to talk about the treatment options which we have on the erectile dysfunction and also the other related diseases, the Peyronie disease or other ischemic diseases, we are also going to play a major role. And now, I'm a surgeon, as we are involving when we have a carcinoma of penis. Now it has become a passion, or not passion, it is a routine that after treatment we always ask the question that how you are going to reconstruct the penis and what kind of implants you are using. That has become a part of it, in which 2 3 years back we never used that question. When we say somebody says total penectomy, that is fine, but now today a postgraduate of even a surgical side cannot go just say that I will do a penectomy and come out, and he has to come out with artificial ways and means how the implant or reconstruction of the penis or a lot of plastic surgical procedures also has come in. So both the side, either the person who has the physiological disease or when a person is having a pathological disease, at the both the side, the surgical knife is able to give some relief that the experts are going to talk. I'm also very fascinated by the passion with which Dr. Deepak sir is promoting the speciality on the sexual medicine to be developed both in the curriculum of the National Medical Commission and the National Board. I think even the last few weeks back, we had the National Governing Council meeting of the that had a discussion on the sexual medicine, and it is in a very positive state. I'm sure very soon the at least level on the diploma level or even a master degree on the sexual medicine possibility is or more, because more and more people have started thinking on that, like what the more importance of dermatology, something going for the cosmetology. So now they are thinking separately on the cosmetology. Similarly, on the venereal disease and other disease pattern, now the wellness pattern on that sexual medicine, which encompasses a large sector of the people. So that is also on the anvil. I assure Dr. Jumani sir, the Indian Medical Association will be constantly voice for that, and we will be definitely putting this our views on this. We are IMA as very effectively. We are having a men's health, because that is one of the area where we are taking it up. We know there is a lot of other issues on the men's health, that more we are focusing on andrological part and especially the sexual health part. We are emphasizing on that need. That is why Indian Medical Association has done fellowship courses, certificate courses, and that all benefited a lot. That has, I mean, it is not just because the knowledge to give to the doctor, but it is going to have a social responsibility and help the millions of people to get that input and right knowledge to the people. So I am extremely happy and delighted to be part of this program today. I wish all the best for the speakers to give this input, and if I will request Dr. Jumani sir, you can give it as a right article, and how best the knife treatment or the surgical implantation can be helpful, and we will be able to put it in our website, and also able to send to our Mumbai, so that will be a great help. So we do not know who in a crowd who needs this help. It is still there is a who is there. So if we can make it available, someone will use that. We can benefit that. That is an ultimate benefit of organizing such a CME. So we will be always with you. Thank you very much. I officially declare this program is open.
Thank you very much, sir, for those pearls of wisdom. And thank you very much. And I'm aware that you would definitely be proactive and fight for our rights and bring sexology to the other, to equal to the other faculties of medicines. Thank you very much, sir, for coming and joining and sparing your valuable time and blessing us. Let's move on to our academics today. We have our first speaker, as we know, is Dr. Rupin Shah, who is a microsurgeon, urologist, who's got special interest in sexual health. He is one of the best surgeons, done maximum surgeries, and winner of BC Roy Award, and a very good teacher and a humble human being. He is always there to help us anytime when you ask any help. We have seen him in conferences in many small count. He tries to help and teach anybody who seeks help from him. He's going to tell us about implants. One of the implants which he has invented is the boon to every common man who needs surgical treatment for erectile dysfunction. It's cost effective, very cheap, and it's equal to the American implants which are available. He will also cover some aspects of varicocele surgery because Dr. Rajiv Kumar may not join. So I request Dr. Rupin Shah, put your hands together and welcome Dr. Rupin Shah. Over to you, sir.
Thank you very much, Deepak. Thank you for that very warm introduction. We've known each other now for 30 years maybe, and it's always a pleasure to be part of one of your meetings. In fact, I want to compliment you. All through this lockdown, you've been amazingly active, organizing lecture after lecture and webinar, an entire series. So you've been playing a very active role in education. So compliments to you, and thank you to Zydus and the others who have supported you in this wonderful endeavor. So thank you for inviting me to be part of the session today. It's always a pleasure. So we're going to talk about penile implants today, and I'll give a brief few words on varicocele if Rajiv is unable to join. Can I confirm that my screen is seen and I'm audible?
Visible, sir. You are
Sure.
perfectly audible, sir.
So if nothing else works, then the final cure is the penile prosthesis. And interestingly enough, studies have shown that the highest patient compliance and satisfaction, more than even the oral medication, is finally with the penile prosthesis. However, a penile implant is a surgical cure, and therefore it is always a latter line of treatment. Interestingly, in the recommendations of the International Society of Sexual Medicine and the American Urology Association, in the previous guidelines, penile prosthesis was a level 3 treatment. So you tried level 1, which was the oral medication and the counseling, level 2, which was the injections, and then moved the patient to penile prosthesis. And the latest guidelines, which have just been presented, they've eliminated that distinction, and they've said that it may be valid to consider penile prosthesis even as a level 1 intervention. Actually, I don't agree with that. I still feel that it should be level 3. Patients sometimes don't know what they want. They may come and say, I want the implant, and that may not be the required necessary treatment for them. But the change in guidelines does indicate a greater acceptance of the role of penile prosthesis in resolving problems. So you can see in this cartoon, a penile prosthesis basically comprises of two silicone rods placed within the entire corpora cavernosa, thereby making the penis erect. And today we'll talk about when such a device is needed, when not, which devices are available, and we won't talk about the how today. That is something for a more surgical audience. So when do we consider a penile implant? As I said, now the indications and guidelines have changed, and the current recommendations are any person with erectile dysfunction could consider an implant. I don't agree. I still feel that when a person comes with erectile dysfunction, you should have counseling, understand their needs, their problems, the environment in which the sexual dysfunction has arisen. Try an oral PD5 inhibitor, try one or two different oral inhibitors. If that doesn't work, try intrapenile injections and let the patient work his way to an implant. During that time, you get to understand the patient gets to understand his limitations. He realizes that everything else that he has tried has not worked, either because of severe arterial insufficiency or because of a venous leak, sometimes primary in young men, often acquired in older men with atherosclerosis. And then realizing that nothing else is working, he is happy and delighted to have an implant. Another group of men are those who have severe cavernosal fibrosis, which may happen from a priapism, and we have a talk later on by Dr. Sood on priapism. But if a priapism is not treated in time, it can cause permanent damage to the penis, and in such a case, the only cure is a penile implant. And sometimes there are patients who've had an implant put in, it got infected, it's taken out, then they have a lot of fibrosis, and the only cure for them is a reimplantation. Then we have unusual indications. There are some men who have a new penis reconstructed, and our chief guest did mention it following amputation of the penis, but there are many other indications, microphallus, transgender surgery, etc., where using a radial forearm flap or a latissimus dorsi flap, we reconstruct a whole new phallus and rejoin it to the pubic area. And once it has taken properly, then a penile prosthesis is placed inside to give stiffness and rigidity for intercourse. And then there are rare conditions. Sometimes you get men in their 70s, very big belly, very short penis. They are unable to find the penis to pass urine. And sometimes you have to put in an implant just to pull the penis out so that they can pass urine easily. Now, when not to implant is perhaps even more important. And there's an important point here. In my practice, if someone is responding to oral medication or to an intrapenile injection, and then he comes and says, Doc, I heard about the implant. I think I should go in for an implant instead. I will not implant such a patient. Because in my experience, if someone is getting a natural erection, even with the tablet or the injection, that natural erection is always better and superior to something which is artificial. Implants give excellent erections and excellent function and excellent satisfaction, but they're best appreciated by someone who's close to zero, who's not getting anything. And then when he gets an 80-90% erection, he's delighted. But if someone is getting a 90-95% erection with medication, then he may be disappointed with the implant because after all, it is artificial. And therefore, my personal recommendation is not to go for an implant if other measures work. Now, sometimes we get men who seem to be psychogenic, but nothing has worked. They've taken double the maximum dose of PD5, they've taken intrapenile injections. They're usually young people, their marriage is on the verge of divorce. Nothing is working. In such cases, after a close psychiatric consultation, after discussion with the sexologist who prepares the patient, we've had occasions where we've implanted such men and they've gone on to have very good results, but with a lot of supportive counseling. Now, this is a case which is very tricky and is for the urologists. We see a lot of young men who had a road accident, fracture pelvis, rupture urethra, one urethroplasty, two urethroplasties, the penis falls back. There's a huge loss of length. So here is a man, his stretched penile length is 4 centimeters, severe vasculogenic ED. Even when we inject into the penis, there is no erection. But if we were to implant him, his length is going to be only 5 centimeters, and that will still not be functional. So implanting him is of no value. And we've seen such men who've received implants and they're completely upset at the result because somewhere in their mind they think that the implant is now going to make them as good as original, and it's not possible. So you have to see sometimes the patient has lost length due to a number of reasons. Trauma, as you can see here, Peyronie's disease, severe fibrosis, and you need to be very careful in counseling and implanting such patients. There are contraindications which are quite obvious: very poor control of diabetes or infection. Spinal cord injury, we prefer not to implant because the complication rates are high. They are better off using intrapenile injections or vacuum devices. If there's severe outflow obstruction, that needs to be resolved before we put in an implant. And if someone has severe psychiatric disturbances, no libido, alternative sexual preferences, and sometimes they come thinking that the implant will solve their psychiatric or sexual disorders, and it will not. An implant just makes a man capable of intercourse. But if he thinks, no, it will change his orientation or his preferences, that won't work, and we have to be very careful in deciding when to operate an implant. So now, which implants are available? Implants basically fall into two groups. One is the non-inflatable. The non-inflatable means the implant is of constant length and constant girth. So when it is put into the penis is in a state of permanent erection. Now that sounds scary and horrible. Not really. Patients are very comfortable with that. So how do they go about their daily life? Well, the non-inflatable implants are again in two types. To the left, you see the malleable implants. So in the center is a metal core, which makes it malleable. So when you bend the implant, it will stay bent. And when the man wants to have sex, he straightens it out manually, and then he can have sex. And that is how concealment is achieved. To the right, you see a different concept. That is the Indian implant or the Shah implant, where the front area is strong and stiff, but the central area, as you can see, is soft and flexible, which makes the implant bendable at that point. So the implant is positioned in the penis such that the flexible zone lies at the base, the stiff zone is in front. So as a result, the penis becomes quite easy to conceal. This is what it would look like. A man who has a Shah implant wearing the underwear, you can't see it because the underwear tucks it down. He can even wear tight pants without any problem. When he removes his clothes, he needs to support the base for entry, and then he can have very good sex. The Rolls Royce of the implant is the three-piece implant, which has inflatable cylinders, a pump, and a reservoir. So this is how it fits in the body. The cylinders are in the penis, the pump is in the scrotum between the testes, and the reservoir is in the retropubic space. So the penis actually looks normal, hangs down. And when the man wants an erection through the scrotal skin, he will feel the pump squeeze it, and that will transfer fluid from the reservoir into the cylinder. The cylinder will fill up, it will expand, it will fill up the whole corpora. Some of the cylinders can even elongate a little, and thereby it produces a full erection. And once intercourse is over, the man presses the release valve, the fluid flows back, and the erection settles down. This is another type of three-piece from the Coloplast company, not available in India. And this is a new implant which has just become available from a different company. And the good thing about it is it comes with a lifetime warranty, and we'll talk about that in a moment. So how do these implants compare? Well, there is also a two-piece inflatable, but that's going to be withdrawn from the market, so we need not worry about that. So basically, we are comparing the non-inflatable, either the malleable or the hinge, versus the three-piece inflatable. So the non-inflatables are easy to implant, both for the surgeon and the patient. They are stable devices. They should last a lifetime. They're easy to use because there's no component that needs to be pumped up or altered or positioned. Just raise and support the base and you're ready to go. And therefore, for older men who don't have much manual dexterity, it is very good. And compared to the three-piece, it is a lot less expensive. So the imported malleable is about 1,25,000 to 1,50,000. The Indian malleable, which is the Indian hinged implant, is 23,000. So that makes it very affordable. By contrast, the three-piece inflatable costs between 7 to 8 lakh rupees for the implant alone. So that's very expensive. And only some patients can afford it. Because it's a more complex device, there will be a certain percentage that experience mechanical failure. It's a more complex surgery, so not everybody does it. And the patient needs to be able to have the ability to compress the pump, deflate the pump. So if somebody has Parkinson's or poor strength in the hand, he may not be able to use the three-piece. On the other hand, the three-piece does give the best possible erection because it inflates girth-wise to fill up the corpora. Some models even elongate to stretch the penis. So it resembles the natural erection most closely. The non-inflatable has a fixed length and girth. So it is good. It is functional, but not as good as the three-piece. The rigidity is better with the three-piece and the concealment is superior. So there are pros and cons. Someone says, doc, money is not a concern, then we would go in for the three-piece. If somebody says money is a concern, or I want something simple, or I want something guaranteed not to fail, then we would go in for the non-inflatable. Now, here are some common questions, and with that we will end because there are many other talks. These are questions the patient asks. Does it feel natural? Somewhat natural, because in a natural erection, the penis is soft. And when there is sexual arousal, it fills up naturally. With the inflatable, it comes close to that, but it is not completely natural. With the non-inflatable, it feels reasonably natural because often there is some degree of erection over and above the implant. Will the size increase? Will an implant make my penis bigger? No, an implant actually makes the penis a little smaller than the best possible erection. And it is important to counsel the patient that the erection will be a little smaller and a little narrower than his best erection that he remembered. Will he have sensation? Yes, sensation doesn't change. Can he reach an orgasm? Certainly. Will he ejaculate? Certainly. Can he father children? Many of them have fathered children. What about the partner? Will the partner be satisfied? Usually, yes, unless the patient has lost length due to fibrosis. With the implant, the erection is very good. Sex can last as long as they like, and partner satisfaction can be very good. Will the partner know about the implant? Now, if it's an inflatable implant, there is a pump, there is tubing, and if the partner feels the scrotum, they may feel something. With the non-inflatable implant, it is entirely concealed within the penis, and there is nothing to tell the partner that there is an implant other than the fact that the penis is always erect. I've had men come back 10 years after an implant. They got married after the implant. Now they have 2 kids, and I ask them, so what does your wife say about the implant? Oh, my wife has no clue because sex takes place in the dark. I have the erection. We have great sex. She's happy. I put on my clothes and it's done. How long will the implant last? The non-inflatable should last forever. The inflatable, at 10 years, there is about a 25% failure rate. The AMS implant has a 5-year warranty. The Rigicon, which I showed you, comes with a lifetime warranty. So anytime the implant fails, the company will give the replacement free. Complications, the only real complication we are worried about is infection. And therefore, I'm often asked, can men with diabetes undergo an implant? So here was a large study looking at men with all kinds of HbA1c levels. And what the study found is that if a diabetic man has good HbA1c control, the infection rate is as good as anybody else, which is about 2%. So the real complication is infection. There are other minor complications, but they can easily be overcome. So to summarize, the penile prosthesis is the final step, but it is often the most satisfying step and certainly can give a very good outcome once it is combined with proper advice, proper counseling, and proper selection. So thank you, Deepak, once again for inviting me to share on this very important topic, and we can have questions now or later, depending on how you have planned it.
We can have later after Dr. Sooth finishes his talk. And you will also have to take a little bit on varicoceles once Dr. Sooth finishes his talk. May I invite Dr. Rajeev Suth, another fantastic neurosurgeon, another BC Roy Award winner, and a very great, humble human being, has been always been service oriented throughout his life. Please put your hands together and welcome Dr. Rajeev Suth. One of the main things about Rajeev Suth is that he is a crusader for men's health. We all know that men die earlier than women, and he is doing so much in the field to develop an opinion and develop something in the field of medicine to see that men live longer. Over to you, Dr. Rajeev Suth, sir.
Thank you, Dr. Jomani. Actually, this place is quite noisy, and I'm trying to go to another place, therefore, and I'm thankful to you as an organizer, and this all Dr. Rupin Shah, Dr. Jialal is there, who has inaugurated our program today, and let us start my presentation. Please don't mind for 1 or 2 minutes if there is some disturbance.
No issues, sir. No issues.
I am trying to solve it, and please bear with me for a minute. I'll share my screen. I'm very. Can you take another lecture before
No, Dr. Rajiv is not there. You're the only one to take.
Huh? Pardon.
Yeah, we can see your slides.
You can see?
Yes, we can see your slides.
Okay.
Just make it on a slideshow.
Okay, I'm just doing that. There's some problem. It is not coming as the full screen. Let me try again.
Sir, open your download slides.
No, I'm doing.
Go on the slideshow and start from 1.
Yeah,
Go up on the slideshow and start from beginning. Yeah, now it's okay.
Is
It's okay, sir.
Okay. So, my job today is to talk about the painful conditions of penis, and these are the triple P, which is priapism, Peyronie's disease, and also the penis fracture. So, when I deliberate on these topics in front of all the stalwarts who are also today presenting the slides and presenting the various conditions, and when Dr. Rupin Shah is there, who was the person in India with whom I was the co-convener of the andrology subsection, and from where I started. I'll now mention like to mention that Peyronie's disease I'll take first. And Peyronie's by definition, it is the fibrotic induration of the penis with concurrent curvature. So two things are there. There is fibrotic induration in the penis, and also concurrent curvature is there. It was described by Francois Gigot, the law Peyronie, almost 300 years back. And it is also known as induratio penis plastica. The peak incidence in 4th to 6th decade and pain and penile curvature during erection is there. There is difficulty in the intercourse. Importance is in some cases is also associated, and a hard fibrotic mass is felt on palpation. Now, in the etiology, what happens? There is repeated microtrauma in most probably the inciting event in this disease entity, and we should always examine the hands. And in the hands, one may find with the similar kind of etiopathology, the deuterine contracture, which has been associated with the Peyronie's disease. There is a possible genetic etiology also. In the etiology, as I have explained, because of this penile repeated trauma, penile trauma, which has been given as the causative factor, there is attraction of inflammatory cells and the platelets. And you know, whichever are the inflammatory conditions, maybe the other inflammatory conditions in the body, maybe obesity, or maybe there may be diabetes even. These are all inflammatory. And in the corona period, I'll like to share with you that my two of the patients who had Peyronie's disease, they were one was operated already, he was member of parliament, and the other one, who was my very dear colleague and friend, both had Peyronie's disease. And the other one, who was the colleague, he was about to be operated, and we lost both of them because the inflammation of corona. And what I presume that inflammation of corona and inflammation of this Peyronie pathology, they have something in common. And I have seen in my database that those who were having Peyronie's disease and who had COVID, they had a bit of severe disease. So this is my observation, which needs to be substantiated. The clinical course is self-limiting. It is divided into acute and coronary phase. And in the acute phase, there is pain initially. Patient complains of that, worsening of a deformity, and enlargement of the plaque gradually. And it takes 12 to 18 months to stabilize that condition. And when it becomes chronic, there is no pain and stable deformity is there. The medical treatment which has been offered and which has been proven to be beneficial can be oral therapy. And we had been given vitamin E, potassium para-aminobenzoate, colchicine, tamoxifen, and pentoxifylline. So many studies and papers are there, but we were awaiting the FDA approval. None has that. And then transdermal therapies are there. Verapamil, which is antihypertensive, that has been proven to be beneficial. Intralesional agents, again Verapamil half ml, which we had been injecting for last 20-25 years frequently. Interferon A, when it came to the market, we were injecting, but interferon alpha 2 beta, this has anti-inflammatory effect. Simple saline infections have also broken the this fibrotic patch, and intralesional therapies are supposed to be not the cure, but more for the prevention of further progression. Only FDA approved agent, which till date is Xiaflex. What is Xiaflex? It is very costly. It is FDA approved, but people are not able to afford it. It is carcinogenous Clostridium. And what happens when we inject it? It gives it. You have to inject 2 or 3 sittings, and you have to do modeling. You have to bend the penis in the opposite direction from the curvature. And also this Xiaflex I have given only in one patient because it is very difficult to afford, and there are some hematoma and other complications also. It is very difficult to repeat this treatment once it is given, and if the complications are there. Other therapies, traction therapies are there, andropenis, which is freely available on internet also. This can give some relief if it is the angulation is less than 30 degree or so. We can expect some benefit. Or there is ESWL, which has not very high level of evidence of benefiting the patients. Now, the surgical treatment after the disease is stabilized, that can be done, and there are 3 types of surgeries. One is modeling, remodeling, that this all has been employed, and in this diagram of this surgical treatment, if ED is present, then we give the penile prosthesis. But if ED is not there and the normal length or less than 30 degrees there, then penile shortening procedures are done. That is net split plication. We do plication, so penis is shortened, but it becomes straight. But if the short penis is there, or the angulation is more than 45 degrees, then penile lengthening procedures are adopted, and grafts are done. Grafting is done when we excise or we partially excise the plaques. And these are the procedures. We palpate the penis or stretch the facilitates the identification of the plaque also, and measurement of the curvature, and with the goniometer is done. This is the procedure which is shown. And after that, instability or hinge effect of the erect penis caused by indentation is demonstrated in the severely dorsally bent penis with application of axial pressure. And this becomes more prominent, and we come to know that which side is the angulation and how much is the angulation. Penile shortening is shown here with the plication, which I was mentioning. And with this, the straightening is done, the cord is removed, and also penile prosthesis can be put. And about Dr. Rupin has explained about the penile prosthesis. And if erectile dysfunction is also associated, we can resort to this procedure and surgical treatment. So Peyronie's disease, other modalities have been tried, many procedures have been tried, but the main ones I have discussed. Now coming to the second painful penile condition, that is priapism. And when we talk about priapism, it is quite threatening, it is quite painful mostly, and also unless it is non-ischemic, it is painful. And in priapism, it is full or partial erection that continues more than 4 hours beyond sexual stimulation and orgasm, or is unrelated to the sexual stimulation even. And there has been instances when the self-injection of a bimix, trimix has been done, or there has been even sometime the oral PD5 inhibitors have been given, and that is unusual, but the incidences are there. And this priapism is persistent erection And this can be ischemic when the low flow is there and ischemia is caused, or there can be non-ischemic where the high flow is there because of the fistulas or because of some reasons there is high inflow, but the outflow is not obstructed. And this is usually non-painful. And then there can be stuttering priapism, that is the erection and resolve and then erection and then resolve. This is some extension of ischemic priapism. So first we talk about ischemic, where we know occlusive or low flow is there. And in this, the persistent erection is marked by rigidity. There is hypoxia, hypercarbia or acidosis, and changes begin after 4 hours and peak level is 24 hours. The patient typically complains of penile pain and examination reveal rigid erection. Analog to the muscle compartment syndrome is the correct definition, and initial occlusion of the venous outflow causes subsequent cessation of arterial inflow because of the erection and compression. And at 12 hours, there is interstitial edema. When the time passes 24 hours, destruction of the sinusoidal endothelium, which is the very important event, and exposure of the basement member and thrombocyte adhesions is there inside the penis. And also at 48 hours, if it extends, the thrombi are formed and in the sinusoidal spaces, and smooth muscle necrosis occurs, which leads to erectile dysfunction. And beyond 36 hours, if it is lasting, then sometime we resort to penile prosthesis simultaneously when we are treating it, because inevitable erectile dysfunction settles. And therefore, ischemic priapism, where veno-occlusum is there is low outflow, increased intracavernosal pressure, and decreased arterial inflow because of that, and stasis of the blood, which causes hypoxia, and painful, fully rigid erections are there. It is an emergency. When left untreated, resolution may take days, and erectile dysfunction is invariable. And stuttering priapism, when we were talking, this is characterized by the repeated, unwanted, and painful episodes of the prolonged erections. Sickle cell disease is one of the causative factor, and due to the obstruction of the venous outflow by the sickled erythrocytes, may start from childhood and progress in frequency and duration, leading to a full episode of unrelenting ischemic priapism. Any patient experiencing ischemic priapism has risk of stuttering priapism. And when we talk about non-ischemic now, the priapism, it is the high flow. It is the arterial high flow. The inflow is increased. And what happens? The persistent erection caused by unregulated cavernosal arterial inflow causes our trauma, arterio-sinusoidal fistula. And what happens when it is increased inflow, then as it was in the ischemic priapism, also more, outflow is also more, and persistent erections are there, but they are not painful. And what happens, that most common causes may be, other than these fistulas, the straddle injury, the coital trauma, kicks to the penis or perineum, complications of the penile diagnostics, vascular erosions complicating metastatic infiltration of the corpora, there is nodules in the corpora, or iatrogenic trauma from cold knife urethrotomy, corporoplasty, and penile revascularization procedure. In this arterial high flow priapism, which is non-ischemic, the tumescence is there, but rigidity may not be there. Penis is not painful. The cavernosal environment does not become ischemic, and blood gases do not show hypoxia, hypercarbia, or acidosis. Once properly diagnosed, does not require emergency intervention. So normal erectile function has been reported even after recovery, unlike ischemic priapism. And these are the differences. Basically, where perineal trauma is usually the cause of non-ischemic, it can be cavernosal inflow on Doppler. We can demonstrate, and otherwise in ischemic, there is hematological abnormalities, corvora cavernosa is fully rigid. There is a penile pain, abnormal penile blood gases. These all are the features which differentiate it from non-ischemic priapism. Now, in the history also, in the emergency room, when we assess for the priapism, we should talk about duration of erection, presence of pain. As I have explained to you, inciting event. What was the inciting event? That is also important. Previous episodes of priapism were there or not there, and medications, recreational diseases, any history of sickle cell disease, hemoglobinopathies, hypercoagulable states, and any leukemias or other problems are there. Baseline erectile dysfunction is important. Presence and duration of the morning erections and use of phospho-PD5 inhibitors, they should be asked from the patient, and then patient should be examined in the case of priapism, and corpulent bodies may be completely rigid. Glans penis and corpus summagism are not rigid at that time. Malignant infiltration, as I have explained. But in non-ischemic priapism, penis is non-tender tumescence or partially erect. In non-ischemic priapism, the corpora will be tumescent but not rigid. And this is all the checklist which has been publicized by AUA. And in the management of ischemic, what we do, we investigate fully as the routine investigation, CBC, blood count, and with blood white blood counts, and with blood cell differentiation, platelet counts, and coagulation profile. Sickle cell belt, if we are dealing the patient, then accordingly electrophoresis can be done, and urine and serum toxicology is important. Corporal blood gas diagnosis and therapeutics are important. Reveal a dark deoxygenated blood with a crack case oil appearance is there, the hallmark of ischemic priapism. If you keep on aspirating, initially it will be very dark, and gradually the bright, if you keep on aspirating, the brighter side of the blood come if you are early in the treatment. And these are the syringes you see. Initially they are very dark, blood is what deoxygenated, and subsequent aspirations will show brighter blood aspirate. And the color Doppler, as I have explained, that is quite handy, and we can make use of it, and especially it will tell you whether it is non-ischemic priapism. And after initial conservative measures which are applied according to the time spent, local anesthesia of the penis is important, and insert wide bold butterfly through the glans into the corpora cavernosa, aspirate the cavernosal blood until bright red comes, is aspirated, cavernosal irrigation is done with the 0.90 saline solution. Intracavernosal therapy includes inject intracavernosal in adrenoreceptor agonist. Current first line therapy is phenylephrine with aliquots of 200 microgram being injected every 3 to 5 minutes until deuterosemescence is achieved. Maximum dose is 1 gram, that is 1000. So if you are giving 100 micrograms, then you can give 10 times. And if you are giving 200 microgram aliquots, then you can give 5 times. And it is 1 milligram within 1 hour. So coming to the surgical therapy, we do the stenting. What is the stenting? We stent between because from the cavernosa, the blood is not draining out, and therefore it can be drained to the place. All the operations are dependent on that, how we re-establish the drainage from the cavernosa. And surgical stunting is therefore done. You consider primary penile implantation if it is quite some time since the priapism is there. Aspiration I have already explained to you, and also this is important that we are on the top side we are avoiding nerves and blood vessels. And on the downside, there is a urethra that is to be avoided. And this is the way we inject on this plane at 90 degrees, the injection goes. This is 3 o'clock and 9 o'clock positions. And we hold the penis firmly between thumb and the index finger. And accordingly, we direct our needle and start the procedure. The drugs, phenylephrine is quite handy, and I have explained. Other drugs are etilephrine, methylene blue is also used. When 50 to 100 milligram is left for 5 minutes in intracavernous, and it is then aspirated and the penis is compressed for an additional 5 minutes. If it is a child, you can use the BP cuff, the pediatric BP cuff on the penis can be applied, and gradual compression and decompression can be done. And adrenaline and terbutaline are the other drugs which are used. And if it is sickle cell disease, we give analgesics, hydration, oxygen, bibarb exchange transfusions are important. Hydroxycarbamide can be used in vaso-occlusive crisis. And when on the electrophoresis, we find that fetal hemoglobin is there. Reduction of the WBCs, platelets, reticulocytes, and promotion of nitrous oxide is helpful. Hematological consultations can be done. And high success rate from aspiration, injection, irrigation is there, and due to emergence for 30 minutes and then discharge. The shunting, which I was talking, that we have to establish the drainage of the cavernosa if we want to prevent the further injuries, the ischemic injuries. The International Society for Sexual Medicine, the Standards Committee stated that shunting is to be considered for ischemic priapism events lasting 72 hours or less. If it is more, then implants are the only solution. Principle is to re-establish the corporeal inflow by relieving the pressure of venous, by relieving the venous outflow, and also we establish a fistula between the corpora cavernosa and the glass penis. And by that way, we establish, or we can establish this fistula between the dorsal vein or even the saphenous vein. And various the operations have been explained. These are the percutaneous distal shunts. Winter shunt is quite safe and quite easy. With the true cut needle in our armamentarium, we can easily do it. And for last almost 45 years, we are using winter stunt, and it has not been replaced. This is our first choice in the early phases. Or we can do the hose shunt also and T-shunt also. I'll explain that how it is done in the distal shunts. And open distal shunt is also possible. That is Al-Gorab or corporeal snake, or there is a combined T-shunt, that is the distal shunt, and corporeal snake maneuver, which was explained in 2014. Open proximal shunts. Now coming after distal shunts, there are proximal shunts. in the penis, and these are quackles or stature. Shunt is there. Saphenous vein is gray hex shunt, and deep dorsal vein shunt is by Berry. These all have been explained. A distal caverno-glandular shunt should be the first choice. Winter shunt I'm using the most, and technically it is easier to perform. Percutaneously distal stunting is less invasive. It is very less invasive and very easily done, and it is the open distal shunting, and can be performed with local anesthesia in the emergency department as the office procedure also. Percutaneous shunts, which we are, this is the T shunt, we insert the knife and just rotate it. And you are seeing in this cartoon at the lower part that how we insert and then rotate it, and it is T shunt with or without tunneling for prolonged ischemic priapism. It was described in 2009 by Brandt, and then there is Winter shunt, which has been tested, and large bore needle or true cut needle is employed, and you know that true cut needle is used for taking biopsies. And with this, not only we can make the shunt, but we can get the tissue also for the biopsy, and it is done on both the sides of the glans, and two shunts are created. And those shunt can be there, which is multiple tunical incisions. Windows are made between the glans and each tip of the corpus cavernosus by means of a size 11 blade scalpel passed several times from the glans percutaneously. And open shunts, which I was telling after these shunts, is L. Gorav. This is the distal shunt where we make the open corporo-glandular shunt. It is indicated if PC shunt fails, and also open proximal shunts are done for failed distal shunts, and established communication between corpora cavernosa and corpora spongiosum at the base of the penis. So this is not at the distal end. These proximal shunts are at the base of the penis. There is increased thromboembolism, then it is required. And Quackel's technique is the open technique, where transscrotal, you can see the incision, or perineal approach is taken. A proximal open shunt technique creates communication between corpus cavernosum and the corpus spongiosum. Both are lying side by side, and we create open shunt between two. And complications are unwanted urethral cavernous fistula and urethral stricture or cavernositis. And stature cavernosan spongiosal shunts are there. Bilateral shunt created between the urethral bulb, you can see in the perineum and the crura. The right side and left side are separated by 1 centimeter to minimize the urethral stricture. So these are the now proximal stunts, and gray hack cavernoso saphenous stunt can be done by mobilizing now the saphenous vein. So we drain the cavernosa through saphenous vein. We mobilize the saphenous vein from below the junction of the femoral vein and take it above as the tunneling you are seeing to the penis, and then we just anastomosis, and there is a complication which is possible, saphenofemoral thrombus formation and pulmonary embolism also, but they are not that frequent. Deep dorsal vein shunt can also be employed, and this is anastomosis to the tunica albuginea. Wedge of the tunica is excised to proportionate to the size of the dorsal vein. Penile prosthesis, as I was mentioning, that if it is more than 72 hours, then we can use the penile prosthesis. Implantation, immediate implantation is possible, and relative indications include the ischemia that has been presented for more than 36 hours, failure of the aspiration and symptomatic intracavernosal injections, failure of the distal and both proximal shunting. When we have already tried, then you have to resort to penile prosthesis. MRI or corporal biopsy evidence of the corporal smooth muscle necrosis is there. So this is all the systematic representation which I have explained to you till now, and management of the non-ischemic. There is no pain, only tumescence is there, rigidity is not there. The patient can be treated by embolizing the high flow artery, and also pathognomic arteriographic finding of arteriolecular fistula can be demonstrated. And then you can see the fistula blush in this on the left side of the diagrams, and also on the right side the normal is there, and on the left side you can see the fistula blush clearly, and this is to be embolized. And also success rates are very high, even up to 100%. Recurrence rates are, however, 30 to 40%, and normal post-embolization erectile function has been reported in almost 3/4 of the patients, but complications are possible: erectile dysfunction, penile gangrene, gluteal ischemia, purulent cavernocytis, or abscess in the perineum. So this is all the schematic management of high flow priapism. And I have also explained the early complications, but late complications of fibrosis and impotence are possible. There is stuttering priapism. Then the goal is prevention of the future episodes, because it is recurring. Oral alpha adrenic medication is added, which is lifrin 0.5 milligram per kg per day at the bedtime. Baclofen is given oral 40 milligram at bedtime. PD5 inhibitors of sildenafil or tadalafil at low days are handy, and intracavernosal self-injection of phenylephrine may be taught. And oral terbutaline doses of 5 milligram for prolonged erections is the treatment. Now coming to the last of my series, penile fracture, painful penile condition, which is penile fracture also. And in this, the etiology is sexual intercourse in most of the cases, 2/3 of the cases, and especially it happens in the woman on top position. There is force flexion, and that results the fracture in the erect penis. This fracture is the only fracture which is there without bone, and it is in the penis, and it is rolling over condition, and that leads to fracture. And there is a special kind of deformity you can see. This is called eggplant deformity. There is a sudden bleed, and you can see on the top of the picture the eggplant deformity is there. And if spongiasm is involved, it can lead to the urethral bleed and retention of urine also. And we have seen some conditions where urethral injuries are also there. And clinical presentation is as emergency. There is pain, swelling, loss of erection, popping sound. Sudden popping sound is there. And there can be bleeding per urethra if urethra is also injured, and the retention of urine. Ascertain the sexual position in the history, and use of the performance enhancing drugs may be also found in the history. The investigations are penile ultrasound, penile MRI, and retrograde ureterogram if you are suspecting urethral injury, and penile cavernosography, which will show you the tear as you are seeing here, and the extravasation on cavernosography of the dye. And management is adequate analgesia, evaluate the urethral patency, ask the patient to void if he is able to void, and treatment is mainly surgical. Conservative management will fail, and they should not be tried. And surgery is basically circumferential incision, and degloving of the penis is done. We just deglove the penis. Inguinal scrotal incision may also be required sometime. Incision directly over the defect is also made in certain conditions. Adequate exposure should be there where you are repairing. Hematoma should be evacuated, and identification of the tear and repair of the albuginea defect is the key for possible recovery, if at all it is going to be there. Repair of the urethral injury should be done if it is there. And here you can see the tunica albuginea tear is being stitched. You can see it is shattered, and when you deglove, you are finding where is the tear, and very carefully you recover it, repair it, and antibiotic, analgesia, erection suppression drugs are very important, because after operation, there should not be any erection. We add stilbostrol, diazepam for calming the patient, and also chlorpromazine. Abstinence is important for 6 to 8 weeks, and there can be, of course, complication in this condition also. There can be erectile dysfunction, quite likely. Penile deformities occur, urethral sphincter, painful erection, painful intercourse even after the repairs, and skin necrosis, priapism is possible. Fistulas can occur, and which may AV fistula can be there, or uretrocavernosal fistula can be there. Peyronie's disease after this may appear, and which may be very required treatment. So the complication of erectile dysfunction, or maybe fistula or Peyronie's disease may be required. So thank you very much for bearing with me. This is, I've taken a bit, I think, longer time, but these were the 3 different conditions, important conditions, which were to be discussed. And these are the painful conditions of penis, which were to be discussed. And thank you very much for given opportunity to present this webinar. Thank you.
Thank you, Dr. Rajiv, sir, for that very, very exhaustive, very informative talk. You covered every aspect of the surgical treatment of painful penile conditions. There have been a lot of questions, but before we go to the question answer session, may I request Dr. Rupin to give us a little insight and treatment of varicocele surgically. Is it viable? Is it not viable? When we look at the semen analysis, we find semen count, the sperm count to be little low, and the reason could be varicocele, which is diagnosed by ultrasound. And should we treat surgically or should we not treat surgically? Over to you, Dr. Rupin, sir.
Thank you, Deepak. So this I'll keep quick and short. We won't show any slides here, but just the common questions as you listed them. Rajiv, thank you for that wonderful comprehensive talk. So the common question that people face is that, okay, I have a patient whose sperm count is low. Should I refer him for an ultrasound to look for a varicocele? And the answer is no, you should not. And now there are 2-3 things that you need to bear in mind. First, varicoceles are very common, both in fertile and infertile men. Many men will have a varicocele and yet be fully fertile. Many men may be infertile, may have a varicocele, but the infertility may not be due to the varicocele. It may be coincidental. So eventually there's only a small proportion of men who are infertile and have a varicocele, and the infertility is due to the varicocele, and these are the men who would benefit. The current evidence suggests that men who have subclinical varicocele, which means when you examine them, it feels normal, but on ultrasound, they find a varicocele. Such men with subclinical varicocele do not benefit from surgery. If you have a man with low count, low motility, when you examine him, there is no varicocele. Even if ultrasound shows reflux and a varicocele, that man is unlikely to benefit. If you understand this, and most people skip this part, but this is the recommendation of every society. If you understand this, then the first step is not ultrasound. The first step is a clinical examination by the surgeon. And if the surgeon feels the cord is normal, there is no varicocele, the ultrasound is meaningless. Even if the ultrasound, if you do it the other way around, you do an ultrasound and find a varicocele, And then the surgeon examines the patient and the surgeon doesn't find any clinical varicocele, surgery is not indicated. So unfortunately, what happens is a lot of people, in fact, often we medicos, when we don't know what to do, we investigate. So often when you have a patient with oligoasthenia, you feel, no, we have to do something, refer for ultrasound, but that's not true. Ultrasound is done only if you cannot examine properly or you've reached a diagnosis of varicocele clinically and you want to confirm it. So who should be operated? There are many studies which actually found no difference between pregnancy rates in a group of men with varicocele who were not operated versus a group of men with varicocele who were operated. And there are other studies which found that after surgery there was more improvement and the pregnancy rate was higher. So what do we advise patients? The fact that many studies found benefit even without surgery does not mean that men should not be operated, but it does mean that there should be an initial conservative trial. And many of these men will achieve pregnancy during the conservative trial. If they fail to achieve a pregnancy in 3 months, 6 months of conservative therapy, then the next step could be a varicocele surgery with the understanding that, okay, this medicine has not helped. Now we will do varicocele surgery, and that has a 60-70% chance that after surgery, your count motility will improve significantly. And if unfortunately it still doesn't improve, then we would have to move to the next level, which would be IVF, ICSI, or some form of assisted reproduction. One other question, man comes with testicular pain. The first thing very often you're tempted to do is look for varicocele on ultrasound. Once again, the wrong thing to do. For a varicocele to cause testicular pain, first of all, that's not common. You will see a lot of men with large varicoceles and no pain. For a varicocele to cause pain, there should be a typical history. Recurrent episodes of pain whenever the patient stands for a long time or exerts or runs about. One episode of pain and you look for a varicocele is not valid. If there is a typical pain, there needs to be a significant enough varicocele. You make the patient stand for 10 minutes. There has to be varicosity, swelling of the cord, testes drooping for him to have pain. If the patient has stood for a long time and you don't feel any varicocele, then trying to find a subclinical varicocele to explain his pain, again not valid. So pain occasionally may be due to a varicocele, but you have to be very careful about the history. Very often a man who has testicular pain has it because of epididymoarchitis, or he has prostatitis, or some other referred cause of pain. So at this point, I'll stop here because beyond that, it becomes more technical and specific. But these are common errors or factors that even the generalist needs to be aware of while dealing with male infertility and varicocele.
Thank you, Rupin. There have been a lot of questions. And one of the question is, then we give intracavernous injections, Rupin. Which is the drug? Is it papaverine or is it the chlorpromazine which we add causes priapism? Or is it both can cause priapism?
Both can cause priapism. So if you go about injecting every man who comes to you with 30 milligrams of papaverine, probably 1 out of 3 will wind up with a prolonged erection. Chlorpromazine makes it far more efficient. So a man who's getting an erection with 20 milligrams of papaverine will probably respond to 4 milligrams of papaverine with chlorpromazine. So if you gave everybody 1 full ml of papaverine, and if you gave everybody 1 full ml of papaverine chlorpromazine, the papaverine chlorpromazine group is more likely to have priapism because you've used a much stronger preparation. So when you use a bimix, you must always start with just 0.1 ml or 0.2 ml at the most, such a low dose. Which should you use? Always use bimix. Papaverine is a bad drug to use alone. It's not very efficient, it's more painful, it causes more fibrosis. And a lot of men who will fail to respond to papaverine will respond to the bimix.
Okay. Second question, are there any markers where patients who have not responded to PD5 inhibitors, they respond to intracavernous injection of this either bimix or trimix? And are there any markers that who will respond to who will get erections when we give injections, or who will not respond to once we give these injections? Are there any markers or any signs which you can predict before giving these injections?
Eventually, it's only giving the injection that will tell you who will respond. Of course, if the history is suggestive of a very severe vasculogenic ED, such a person is less likely to respond, but you can't really predict. We've had cases where men come and history and everything seems to suggest that he will not respond to the injection. And we give a higher dose and boom, he has a prolonged erection. So I feel you have to give it a try rather than trying to predict he will or will not respond.
And last question, is the role of neurotomy very useful in patients with priapism?
Neurotomy.
Yeah,
I've not heard of neurotomy for priapism.
no. Okay. There's one more question, that is malleable implant in the penis all, and if the penis always remain erect, so patient has to tight penis in the belt, so he gets naturally aroused. So is there any some degree of arousal which remains in these patients who are on implants?
In our experience, 2 out of 3 men who've had a malleable implant still have some degree of tumescence when they are aroused. It will depend on how much erection they had at the time of implant.
Okay. One more question. What is the cost of the Indian Dr. Rupin Shah's implant, and what is the cost of American AMS implants?
So the Shah implant costs 23,000 rupees. The AMS Tactra is about 1,30,000 or 1,40,000.
Okay. And there was one slide which mentioned Dr. Sooth's slide that terbutaline 5 mg is very useful in patients to relieve this. And now, patients who are asthmatic who are taking terbutaline, is it that they will develop erectile dysfunction because of terbutaline?
I think that is a question for Dr. Sood.
Yeah. Dr. Sooth, are you around? Or you can answer this.
Okay, so the current recommendations, in fact, say do not use oral medication to treat priapism. Let's start with that clarity. Because in a state of priapism, there's very little circulation happening in the penis, so the oral drug doesn't reach the penis. And I'm not aware of any data showing that people on terbutaline are more prone to ED.
Okay. Thank you very much, Dr. Rupin, Dr. Rajiv, for this wonderful feast of knowledge which you have imparted so graciously. A lot of things to learn, and I think you've conveyed a lot of messages through your talks. Thank you very much. I thank you all from the bottom of my heart. I thank all the delegates who have been here. I thank Dr. Jayalal. I thank Dr. Maheshkar, Dr. Rajiv Sooth, Dr. Rupin, Dr. Sachin, Dr. Nishant, everyone present here for making this webinar a la grande success. There were lots and lots of take home messages. Of course, the painful penile conditions need surgery, and how to evaluate, how to look for it is very important. The treatment of varicocele is a big question mark surgically, whether we should go for it or not go for it. Clinical examination is a boon, is the right thing to do. You can feel it, and you need a lot of experience to feel this worm like thing in the pampiniform plexus, which is very important. And many things which we learned today. Thank you everybody for making this event a grand success. Over to you, Dr. Sachin.
So
And I also thank Zydus, who are the makers of sildenafil, which is Penegra, Tadalafil, which is Zydalis, Udanafil, which is Udesire, and Avanext, which is Avanafil, and of course Sustanon, testosterone, and of course Erectex, which is nothing but L-arginine and fenugreek combinations. In fact, they have the whole basket for male sexual dysfunctions. I think they should even come out with papaverine and the second line of treatment, and they should also come out with some implants. Over to
definitely.
you, Dr. Sachin.
Thank you so much, everyone. That is, I must say, it is a truly a master class by the experts, and our viewers must have enjoyed it. I would like to thank the Mr. Dr. Jailal and Dr. Maheskar for their guidance. Then I would like to thank Dr. Rupin sir and Dr. Rajiv sir for sharing their knowledge in a very elaborative manner. As Dr. Jumani sir rightly said, there are a lot of take-home message, and we will surely think of it. Then I would like to thank Dr. Jumani sir for their wonderful moderation and driving the session so well. Without your help, it wouldn't have been possible. Thank you so much once again, everyone. And since we are approaching to the Diwali, so and from the entire team of Zydus, I would like to say wishing you a very happy Diwali in advance. Please be safe. And thank you so much for your constant support to the Zydus. As you rightly said, we will constantly work to improve the male sexual health. Thank you so much, everyone. Good night. And we are signing
To
off.
wish everyone a happy Diwali and happy New Year. Thank you all.
Thank you
Happy
so much.
Diwali.
Thank you. Happy Diwali.